How are you guys doing today? I was a bit scared that my camera is not working. Okay, welcome to another wonderful day. Let's see, I'll probably check the chat a little bit later. Okay, I'll check it a little bit later. Hope you're all very well. Day 3 of your 5-day review. Time really goes by so fast. Okay, we are going to go through a couple of things, and then for the last hour we are going to do the mock. Okay, so I'll give you a nice question from our Oxford handbook, and then whoever gives me the 2 full correct answers now ends up doing the mock with me. Okay, so let us begin. And the wonderful saying today comes from my dear mom: heal with your words before you heal with medicine. Yes. She's a good mother. Anyway, let's talk about teaching, because everything that you know, at some point it will be required of you to teach. So you see one, you do one, and then you teach one. That's the cycle of medicine. You saw somebody do a procedure, they taught you how to do it. After you did it, then you can teach somebody to do it. Okay, now every single thing, and I reiterate, every single thing that you do as a doctor, you should be able to do it well and to teach it well. So when people come and ask me, what type of teaching will I be expected to do in the Plab? I say, you see that Plab blueprint with 130 pages, maybe with 20 cases per page? Learn how to do everything and teach everything, from head to toe, in pediatric patients and in adult medicine also. Fluids is such an important concept. Okay, a student, let's say James Smith, has come into the emergency room. Okay, and he wants to learn about fluids, and you are the FY2 doctor, you know, doing the session. Have I been put in this position? Absolutely. So I said, you know, give me 10 minutes. I just have to go check up on a few things. Then I'll be right back and I will teach you. Where did I go? I went to my locker, opened the book, memorized a couple of points and went back. Because if you teach a student the wrong thing, honestly, you're putting a patient in jeopardy. And in any exam, PACES, MRCS, or SKIS, Plab, you are being assessed on how you teach and if the information you're giving to the student is safe. And why would we teach students? Because one day they'll be the doctors. Okay, so my wonderful student James is here and wants to learn about fluids. It's a broad topic. I only have 8 minutes to do it. What will be my focus? In very important things. Okay, so introduction. Hello, James. My name is Dr. X. I'm one of the juniors in this department. Thank you for coming in for the session. Just to clarify, you're the medical student? Yes. What year of medical school are you in? Why? You want to know, because teaching to a 4th-year medical student and teaching to somebody who's just green out of the classroom, you have to learn how to take care of each student's needs according to their level of understanding. Okay, so James is what? A 2nd-year student. And now, what if you have been told to teach a group of students? I mentioned this in my training. Take your level of skill to another level. Okay, what if you're supposed to give a lecture to the whole team? Goodness, you're not going to, you have your consultant there, you have your registrar there, you have medical students. You have to deliver the information in a way where everybody will be intellectually stimulated. So you have to talk about basics, yes, for the medical students, so they can see that they are catered for, and then advance the knowledge also to a level where the consultant is, engaged and saying, okay, this doctor has done their homework. They've looked into evidence-based practices. They've gone into, different websites. They've gone into different medical websites to gather more information. Okay, now let's go back to our student James. Thank you for coming in. Do we have a lot of time for rapport? Because this is where people have problems with time management. It's not time to ask him a question that you don't have time to answer. So there we go. When I do my mocks, James, are you having any challenges? Is everything okay at home? How are you doing? Are you getting enough rest? Are you sleeping well? Get to the teaching. Okay, what if James starts crying? I broke up with my girlfriend. Oh, great. Now I have to counsel you on your girlfriend. Make sure that you're okay. That's going to take me 4 minutes. And then I have to start teaching fluids. You're going to fail the station. Yeah, because you're showing you're not prioritizing. So don't ask questions that you are not ready to sit down and give the answer. Okay, thank you so much, James, for coming in today. You want to learn about fluids. Anything in specific that you want to know? I want to know about maintenance versus resuscitation fluids. Very good, because that is one of my objectives for you to learn today. But let's go through the basics and start about, why we give fluids in the first place. A teacher always finds out the need of the student. You cannot just start teaching without finding out what is their objective. Maybe they wanted to learn about how to calculate, fluid administration in pediatrics. Maybe they want to know the difference between different types of colloids and crystalloids. You don't know. Maybe they need to know how to assess fluid volume status. Maybe they need to know how to document I's and O's. So that's why you want to ask the student, what is your objective of learning today? If they say, I really just came for the session, well and good. Start from the basics. Even people who are experts, it's important just to go through a few of the basics, okay? Now, you have to be systematic and organized. Think about a PowerPoint. Like, what would you want to start with? Why do we give fluids? And when you're teaching, it's not an examination. That's another big thing. I absolutely hate going to some teaching sessions because I know consultant XYZ is just there to pimp us. So we know, as therefore you're like, who's teaching today? Who's teaching radiology? Dr. M. Oh, great. We have to start reading our radiology and getting, what is the difference between a PET and all this other really, really high-end radiology knowledge, because we know as soon as you get into that session, it's not teaching, it's an exam. Okay, but for a student, you don't want that. It's not an examination. So limit your amount of questions to maybe a maximum three or four. One in the beginning, one in the middle, and a couple of more at the end. But you don't want to tell James the student, why do we give fluids? What type of fluids are there? How are fluids administered? What is the fastest way of giving fluids? Can you tell me the difference between colloids and crystal? See you later. He'll never come for another session. So you are teaching, and then you will reassess his knowledge at the end. Why do we give fluids, James? Do you know any reasons why? There are a couple of reasons. Maybe the patient has lost fluid, and there are different ways to lose fluid. It can be through vomiting, it can be through diarrhea, it can be through hemorrhage. There are insensible fluid losses. So the sensible versus insensible, you can add that to your session. You'll really lose a bit of fluid through your respiration, okay? There are also through sweating. That's another insensible fluid loss. Okay, but there are different ways. If we are treating a patient for a condition and maybe we've put an NG tube through the nose into the stomach and we are pumping out fluid, that's a way that they are losing fluid. There are some conditions that make patients really pee out a lot. For example, do you know one of them? Diabetes ketoacidosis. High five. Good job. So now a patient is in a fluid imbalance and you have to replace the fluid, Okay, sometimes we can anticipate that as a patient is going to lose fluids in surgery. So an estimated blood loss, if you're planning for a big surgery like an amputation, you may want to start hydrating this patient earlier on and even have coverage for fluids that they are losing. So sometimes the loss of blood has to be replaced by blood. Okay, so there you go. And what you mentioned to me, there are resuscitation fluids and there are maintenance fluids. Now, before you ever consider about giving fluids, it's important. Go through the patient's chart, find out their medical history, find out their allergies, find out any family-related history, their occupation, all these things. Speak to the patient and do a physical assessment. Sometimes replacement of fluid can harm a patient and put them in overload. For example, if a patient has heart problems, okay, and you give them too much fluid, then you can put them in a state of overload, okay, and they can actually drown. Their lungs can fill up with water. So it's important. That's why you need to take a, I'm looking this side because James, the student, my imaginary student, is on this side, yeah? So don't think I'm not paying attention to you, yeah? So yeah, James, before you give fluids, and this is what you want to teach the students, not to just go, there's an order for fluids, I need to go and start, boom, go start the fluid. No, take a few minutes, do a history, safe doctor, do a history, do a physical examination, listen to their lung sounds, check their skin. There are different things you can notice on a patient's skin to determine their volume status. Okay, and maybe we can go into this a little bit more, especially listening to lung sounds. I may have another session on lung sounds and assessing fluid status through lung sounds. So maybe you can sign up for that lesson in the future. Okay, but you want to check the vital signs of the patient. All right, normal blood pressure, okay, heart rates, okay, postural hypotension, so they are checking a blood pressure when they are lying flat, when they are sitting, and when they are standing, and you're checking if there's a drop in about 10 to 20 millimeters of mercury. Okay, you can see a patient who is dehydrated because their lips are chapped, they have dry mucous membranes. Okay, sometimes their eyes are a bit sunken, their skin looks leathery, so they do not have skin turgor. You know what skin turgor is, James? Try and pinch your skin. You see how it is going back to its normal, after you've stretched it, it goes back to its normal position. That's good skin turgor. Prolonged skin dehydration can be assessed in the skin if you pull out the skin and you realize that it's not going back to its normal formation. A nice easy way so you can understand. Okay, capillary refill is another way to assess. So you're checking the extremities. Is the blood return less than 2 seconds? Few things, guys, to assess volume status. You can check your JVP. Urine output is such an important thing for you to know that an urine output that is less than 0.5 ml per kilogram per hour, you want to really monitor I's and O's in that patient. Their kidneys could not be functioning well. There could be a problem with the kidney. There could be a pre-renal, intrarenal, or post-renal problem. Okay, that's why urine output, ins and outs, input and output are very important when you are thinking about fluids. Okay, other things I've told you, edema, orthopnea, and there are some labs that you can do to assess a patient's fluid status. Okay, urine osmolality, increased serum osmolarity, the patient has hemo concentration, high creatinine, I don't know why I didn't quite print out, okay? So these are some things that can show that the patient is dehydrated, okay? I hope you're making some mental notes, because at the end of this session, I'll ask you a few questions so we can have a mini quiz. Is that okay? No problem, doctor, okay? And now, I've talked for almost a minute. Do I want to hear what he has to say? Yes. Does he need any clarifications? Does he have any questions at all? Okay. These things we are asking the students. Are you with me? Are you following me? Are you paying attention? That's too harsh. Even you, if you're in a session and you're learning and the doctor keeps saying, are you with me? Are you following? I'm here. My ears are open, Dr. M. I'm looking at you. I'm following you, please. So try and don't be an aggressive doctor, okay? Ask it in a different way. Do you need any clarifications on anything that I've said? Okay. Now, when you're talking about fluids, it's important also to know who are you giving the fluids to. Pediatrics versus adults. Anytime we are giving fluids to pediatrics, we have to calculate it according to their kilogram weight. Okay, that's a very important concept for you to know. There are other things I would like to teach you about safety with fluids. So the appropriate cannulation devices. So you can give fluids through very many routes, okay, by the mouth, by IV fluid, regular IV lines, okay, you can give it through the vessels in the neck area, very many routes of IV administration, PO administration, even through NG tubes and G tubes also. There are different ways to give fluids. The most important thing is to maintain patency of the route of administration. That we can talk about in another session also. You know how to assess an IV cannula, okay? How to put in IV cannulas, which IV cannulas are most important for resuscitation, okay? Because if you're going to resuscitate a patient with blood products, you do not want a needle that is going to break down the red blood cells as they go into the patient's body. Okay, if you're going to give fluids in a rapid manner, you don't want a very small needle. It's going to blow. It's not going to last. So there are different gauges of needles that we can talk about, at a different time. Now, if I was going to teach, or again, if I was going to teach this at a more lengthy station, because I want to make this student understand some principles, okay? The body volume of water, the total body volume of water, okay, 40 liters, how it is divided into intracellular fluid volume and extracellular fluid volume, because there are some fluids that will stay in the intracellular place. There are fluids that will go into the plasma, okay. There are some fluids that you give to the patient that will cause dehydration of the tissues. This is such an important concept because you just don't give normal saline. Okay, you just don't give a patient dextrose, because you know dextrose is going to be metabolized. It's going to break down to all this glucose and then it's going to become what? Hypotonic? Yes, it's going to become just like the blood. Okay, it's going to be metabolized. They are different. Would you get into maybe normal saline has this amount of sodium, this amount of chloride, this amount of, that's a little bit too advanced. But I would know it just in case. Just in case you walk into a room and they have a bag of lactated ringers, they have a bag of normal saline, they have another bag of dextrose, and you have to talk about components. So that's homework for you. Go and just look it up. You need to know osmolarity of certain fluids, osmolarity of the blood. You need to know these things, okay? But let me go back to just the basic IV fluids, colloids and crystalloids. They are different types. And they are also in different categories. So all blood is just not the same. There is whole blood, okay, there are packed red blood cells, there's plasma, there are platelets, there's albumin, there are plasma expanders, okay. Whenever you're giving blood products, you have to keep in mind to ask a very vital question, whether the patient has any religious practices, that would prevent them from getting any blood products. We don't want to violate these, but sometimes in emergencies, we can use products that the patient may be comfortable with, but it's important to ask the question, okay. Crystalloids, you have isotonic, which are your normal saline, lactated ringers, your dextrose 5%, hypotonic fluids, hypertonic fluids. Would you want to talk a little bit more what a hypertonic is, what a hypotonic, what an isotonic is? Of course, yeah. And after that, Because he said to you he's interested in learning about maintenance versus resuscitation, don't spend all your time teaching a student what you want to teach them. For example, if they give you the 2-minute warning and you've not touched about resuscitation and maintenance fluids, you've wasted 6 minutes talking about other things. So I would start talking about the student's objectives maybe around the 4th, 5th minute. Okay. Especially if you're an expert, sometimes it gets to be a little bit tricky. Yeah, you're an expert in radiology, in cardiology, a student wants to come and learn how to do an x-ray, and there you go, just going over deep principles, and maybe he just wanted to know the difference between the AP versus PA versus lateral views of an x-ray. Okay, so now resuscitation fluids, the difference between resuscitation and maintenance fluid. Resuscitation, always think of resus. The patient needs those fluids immediately. It's an emergency. So there may be an evidence of hypovolemia or active bleeding. The vital signs will always guide you, James, on how much fluid a patient needs. So for example, you walk into a station. Do I have it here? Good. You walk into a station, and every time when I'm talking about resuscitation fluids with my wonderful students, I always go back to the management triangle, okay? There are 3 important things when you're managing a patient, okay, who is in an emergency. The patient is of priority. And then the monitor or the vital signs or their news chart. In fact, you want a patient on a monitor so you can see the changes that are happening in real time. And then there is the intervention that you take after you have seen the problem. So if you see a problem, there has to be a solution. So for example, James, you're dealing with a trauma case and the patient has a bilateral amputation and they're bleeding out and their vital signs are absolutely haywire. What do you want to start with? Have you ever heard of ABC? ABC, airway, breathing, circulation. Okay, if your airway is fine, your breathing is okay, and your circulation is off, blood pressure that is 60/30, you want to put in 2 large bore IV cannulas. Okay, and I can talk to you because they come in different colors. For example, gray, okay, and orange. Okay, 14 gauge, 16 gauge. These are nice wide bore cannulas that you can give blood products and resuscitation fluids at a rapid rate. Okay, and now here, after you have established IV access, okay, you may want to give the patient a fluid challenge depending on their circumstance. If a patient is unconscious and maybe their vital signs are really not that, critical, maybe a vital sign of blood pressure of like 90/70, yeah, you just don't want to flood them with 2 liters of fluid to resuscitate them. No, you need to do a fluid challenge first. And what is a fluid challenge? It's about 500 ml of normal saline given IV in less than 15 minutes. Okay, and while you're giving the fluid, you're listening to their lung sounds to make sure that they are accommodating the fluids okay, because you may have a patient who has just had a cardiogenic shock. So if you're flooding them with a lot of fluid and their heart cannot pump out all the fluid you're giving them, you may end up in a worse scenario. Okay, just as a recap, James, I've been talking a lot. What can you give me some example of crystalloid fluids? That's how you do it. 1, 2, 3. Okay. If he can't remember, then you can remind him. But you never want to tell a student, can you recap everything that I've taught you in the last 7, 8 minutes? Wow, you don't have all that time. Okay. Maintenance fluids is where most people have a hard time explaining, even in current practice. Okay. I'll teach it to you once and for all, you'll be good to go. Okay. When you're considering a patient on maintenance fluids, of course, you've done your history, you've done your physical examination, you want to make sure you have the lab work in front of you. You want to see the electrolyte needs, because sometimes if the sodium level is too low and you just bump them with water, you're going to drop that sodium even more. Okay, electrolyte balances are very important, and I can even show you some of the ranges maybe for our next session on fluids. Okay, maybe tomorrow. Okay, sometimes it may be important to maximize PO intake. All right, before you consider establishing an IV access. This is maintenance, there's no emergency. So if the patient can drink, if the patient is not having any nausea, any vomiting, if you're not concerned about any other underlying condition that would contraindicate contradict the use of PO fluids, then we would use IV. Okay, but first we try PO. Okay, next, adults need to take at least 25 to 30 ml of water per kilogram in 24 hours for maintenance. What does this equivalent to? 2 to 2.5 liters a day for a 70 to 80 kilogram adult. That's it for maintenance. And then you want to put them on strict I's and O's. Sometimes I's and O's need to be measured with a Foley catheter, so you know what is going in and what is going out. James, do you have any questions for me at this time? He may want to find out, can you recap again what's isotonic, hypotonic, and hypertonic fluids? Okay, he may want to know, what if he asks you a question that you really do not know the answer? Don't lie, don't pretend, just say that's a good question. We can go and check and review together this concept because it is important. I'm glad that you brought it up. Why would you say, let's go and ask the senior? Really? You're going to go and ask a consultant a question that you can look in a book? That'll be the day you'll cry. Don't go and ask the consultant and register things that you can check in a book. Come on. Sometimes in teaching, you need to be able to have resources and even guide the student. Now, this is not all conclusive about fluids. There are some videos I'd like you to watch online. There are some books in the library I can recommend. We can have another question answer session. In fact, maybe you can shadow one of the nurses as they're putting fluids up for patients, and you can ask them a few more questions. They are a valuable resource because most of them have been doing this job more than we have. So try and give your student future access. So am I thinking of the past? Yes. Present? Okay. Future. Are you just going to leave this student with just this information? Okay. Where would I want to go after all of this? I would want to go and reiterate or make sure he's understood how to assess fluid volume status, because that's what he's going to be doing. He's going to be by the patient's bedside. Can he learn how to do capillary refill? Can he learn how to assess a skin tagger? Can he learn how to, can he memorize this urine output? Okay. Can he learn some of the labs that are associated with volume status? That is key for him. Okay. And then in the end, thank him. Thank you so much. If you don't have any questions, see you later. Okay. Here, future continued research and classes to continue adding on to the students' knowledge. That's how you want to leave students. Never just leave them like, okay, if you find a blood pressure that's low, what do you want to do? Put in 2 large bore IV cannulas, let the consultant know or let the doctor know, and then we can take it on from there. What will you do if you go and assess a patient and you find that they have a JVP that you cannot even see, or their JVP is really big, okay, or their jugular vein is really, extruding from their neck? What will they do with that? What will you do if you go and listen to a patient and you hear crackles in their lung sounds? That is the safe information to leave the student with. Okay, please. Now, we'll talk about this a little bit more tomorrow because I want us to talk about some certain emergencies, including, I was thinking of maybe a nice, wonderful respiratory case with a COVID patient, and maybe even a breaking bad news case with a COVID patient. You know, maybe somebody's mother has passed on from the virus, and you have to break the news to the family. Just go to the blueprint. You can make 1,000+ cases of the Plab. Leave these recalls alone. I was in a nice big heated conversation in one of the WhatsApp groups because some doctors, they just want shortcuts. They just want to know, tell me what I need to learn, give me notes, and I'll cram the notes and I'll go and do the exam. And that's not what we do. That's not how I teach. That's not what we do in Plab strategies. We want to give you information that you will use as a doctor. So why would we give you information that is not verified? Books, guys, it's hard work. You signed up for medicine, and so you have to be ready to work hard. Evidence-based practice. What if some of the information here becomes obsolete? You have to know where you need to go. Always question, always question. If I teach you something and like, that didn't sound quite right, go and look for the answer in a book, go and look for the answer in the nice CKS guidelines, and don't leave me in my ignorance. Give me a call. Say, Dr. Lian, you are off in this concept. Please review it. Thank you. Why? It's not a matter of ego. Somebody is going to get that treatment, and you've left me with ignorance. So somebody's going to suffer. And that's why I want to really, that's why the Plab keeps pulling me back. I try to run away, but then when I hear some of the crazy things that are happening in the reviews of this exam, and people just feed me what recalls, I say, abandon these things. Learn medicine, okay? Now, you've taught James about fluids in an adult. Fluids, how about fluids in pediatrics? And I told you one big thing. For every adult case, try and find a case for a for the pediatric population. An adult who has insomnia, can a pediatric have insomnia? Yes. An adult who is having constipation, can a pediatric have constipation? Yes. Okay. An adult who's having troubles with vision, can a pediatric have the same? Yes. So you can double up those cases. Now, in the last 3 days, how many cases do you have? 1,000 times 2, 2,000. Okay, so now this is a parallel case. A medical student, Samantha Jones, now she's a student, and you're in pediatrics. Okay, she wants to learn how to prescribe IV fluids for a 5-year-old Tommy Jones who's 25 kilograms. Hello, Samantha, my name is Dr. X. Are you the medical student today? Thank you so much. No lies and all this faking people are trying to act. Do you know me? Oh, you saw me, I saw you. You didn't see anybody. It's the first time you're meeting, okay? So just say, well, thank you so much for coming for the session. How long have you been on the unit for? I've been here for 2 months. Forgive me. I should have come to introduce myself sooner. Sometimes it gets a bit busy, but I'm glad that you're here, okay? What level of medical school or what year are you in? You don't need to know which medical school she's in. Leave it. What year are you in? I am a first-year doctor. Wow, they are sending you for clinicals this early. That's really great. The more you can transfer your theoretical knowledge into clinical practice, the better doctor you will be. I'm very happy you're here today. Okay, so we are going to learn about fluids. Have you seen fluids being administered before? Do you know why we use fluids? Again, the same principles that we used for James in an adult patient. Okay, why would you think we would want to give fluids to a pediatric patient? I don't know. Sometimes, and children can be a bit finicky, and when they are sick, they shut down everything. They cry. They don't want to eat. They don't want to sleep. They get dehydrated very, very fast. So a big common reason why we would give fluids to a patient, maybe a pediatric patient, is because of dehydration. Maybe we are preparing them for surgery. Maybe we are thinking that in surgery they might need some maintenance fluids, or we might estimate a little bit of blood loss. But it's important for you to know one big thing in pediatrics. most, if not all, things given to a pediatric patient are calculated according to their weight in kilograms, not to their age, not to their height, okay, to their weight in kilograms. Okay, it's very, very important. So let's talk about who we have today. Tommy Jones. So he's going to be getting some IV fluids. Did you get a chance to meet the patient at all? No, doctor, I haven't. All right, let's talk about this and then we'll go and assess the patient, because we can decide to give the patient fluid and then find out that he is already in a fluid positive or in a fluid overload, okay? But it's important for us to know how to balance fluids when administering to pediatrics and what to look for. Would I talk to Samantha about these things here? How to assess fluid volume status in pediatrics? Yes, it's almost the same thing. Dry mucous membranes, their mouth breathers. Okay, well, that's a 5-year-old. Capillary refill, skin tagger. All right, I'll talk about edema. I'll listen to the lung sounds and even the labs. You can actually transpose cases. Anyways, now, there are different types of fluids. We've talked about them. Safety with fluid with fluid infusions. I forgot to mention in the other case, there are some fluids that interact with others. One of the biggest culprits is fluids that have potassium in them. Okay, there are some antibiotics that cannot be given with certain fluids because they form harmful metabolites in the body. Okay, there's also a component with fluid which is IV lines. Okay, and anytime I always tell my students in pediatrics, once you do a calculation for a dose for a child for whatever medication they are going to get, always have somebody cross-check your calculation, please. Okay, until you get to a level where you're really, really proficient. But even at a level where you're proficient, it's always good to cross-check your work. Okay, so we'll find out from the patient what brought them into the hospital. Okay, are they here preparing for surgery? Have they met with the surgical team? Are they waiting for an anesthetist? So these are important things before you just walk into a room and start putting a needle in a patient and giving them fluids. Find out also about the patient's family, the mother and the father or their guardian. Okay, their eating habits. Can we replace these fluids by mouth before we start giving them by IV? Okay, if it's something that is going to be needed for surgery, then of course we are thinking of IV fluids. Yeah? And there are a couple of fluids that can be given, and it is important to confirm again the fluids that need to be given for a patient who is going for surgery. Okay, you can't just assume and tell this student that we give D5.5 normal saline. It depends on the surgeon. It depends on so many different factors. We have to look at the lab work. If the sodium level is low, we'll give them something that has sodium. If the potassium level is low, we'll give them something that has potassium. Okay, we are considering, are they going to be nil by mouth a couple of hours after surgery? Maybe we may need to give them something with dextrose or glucose. Okay, so I hope you're understanding what the principles are, the principles considered when administering fluids in pediatrics. Do you have any questions right now? No? Okay. I hope you have good math skills. Let's take a pen and a paper and calculate fluids for Tommy Jones. So he is 25 kilograms. This has to be unmeasured weight. Okay, not an estimation from the parents. Big thing. Some people, oh my gosh, some people honestly, when I do pediatric medicine, I'm like, what's the weight of the child? It's 12.3. Who said? Did we measure? No, the father said. I laugh too much in the hospital. Betty, how can you, when did the father last weigh his son? 12.5 kilos. And he's a 5-year-old? Really? That boy already looks like he's 30 kgs. Let's put him on the scale and weigh him. It has to be a weight that is done by a doctor, a nurse, or whatever, but by a healthcare professional. Okay, so he's 25 kilograms. And it's important for you doctors to know this, how to calculate fluids in pediatrics. 10 kilograms, the first 10 kilograms, okay, you multiply by 100 mLs, okay, and you get 1,000 mLs. Then the next 10 kilograms, you multiply by 50, half the amount. And anything above, so if this child was 30 kilograms, then you would do 10 kilograms by 20 mLs. What are the magic numbers here? 100, 50, and 20. Those are the magic numbers you need to know for pediatric calculations. 100 mLs, 50 mLs, and 20 mLs. The first 10 kilograms are multiplied. For you to know how much fluid to give for the first 10 kilograms, you do 10 times 100, you get 1,000. For the next 10 kilograms, you do 10 times 50, and you get 500. And anything else above 20 kilograms, then you multiply by 20 mLs. Very, very important. You want to ask the student, please tell me, how many mLs per kilogram are you giving for the first 10 kilograms? 10 times 100, 1,000. Good, good. Okay, excuse me. How about for the next 10 kilograms of the patient's weight? How much do you want to give? I want to give 50 mLs per kilogram. Good, so 500. Now, if this patient is 25 kilograms, our total amount of fluid that we are going to give him is 1,000, okay, mLs plus 500 mLs plus 100 mLs, which gives us 1,600 mLs in 24 hours. If you have to write it out on a documentation sheet, which is important for us to even, I should have brought something from my hospital for you to be able to see. There are certain areas on the prescription that are for IV fluids, okay? But whatever paper you get, you have to make sure the date, okay? You have to make sure the, goodness, you see how long I've been teaching this thing, huh? Anyway, the allergies of the patient, no non-drug allergies, okay? The IV fluid, what are we giving? D5 normal saline, D5.5, normal saline 0.9, whatever, okay? What fluid are we giving in 24 hours? 1,600 mLs in 24 hours. And now the rate per hour, you divide 1,600 divided by 24, and you get 67 mLs per hour. Does the doctor want any additions into the fluids? You need to find out. If you are questioning whether an addition can be added to a bag of fluids, get the BNF. Just check and see if there are any interactions, or make a quick call to the pharmacy. I absolutely love it when we include other specialties. That's why they're there. Quick phone call to them and say, hey, James, it's Leanne, I'm on pediatrics. Please tell me, can potassium be added to D5 normal saline? Okay, just make a quick call instead of just putting in the fluids. We are here to make sure that the patient is safe. And it is very important for us to be safe with fluids, because once it gets into the bloodstream, it gets to the heart, it goes to the brain, it goes to the kidneys, it goes to the liver. The effects of IV fluids are almost instantaneous. So you have to be very, very careful. So this is the order that you write. Now, I'm going to go back again because it's not over. You need to now ask Samantha, did you understand how we calculated the fluids? Yes. For example, what if Tommy Jones is 30 kilograms? Can you tell me how much fluid we are going to give him per hour? So now you're teaching with the consideration that you need to assess her understanding of whatever you have taught. And so you want to watch her do the calculation. For the first 10 kilograms, I'm going to give 100 mLs per kilogram, so I'll give 1,000. For the next 10 kilograms, I'm going to give 50 mLs per kilogram, is equal to 500. And for anything above the first 20 kilograms, I multiply by 20. And so now I have 10 times 20, which is 200. So 1,000 plus 500 plus 200, that's 1700. Did I get it right? Yes. 1700 ml in 24 hours. Then I can just divide and do the long division. Okay. Now, when you are working with nurses, it is important for you to know that sometimes they may want to know how many drops per minute this needs to be infused in. Does it happen all the time? Yes, it does. So sometimes you can be working with a nurse and you say, can you just give this patient 1600 ml per 24 hours? Doctor, just give me the drop factor. Why? I want to just punch it in the machine and we are good to go. Okay, give me the drip rate in drops per minute. So you need to know as a doctor how to take this station to another level. Okay, just in case you work with a nurse who says, can you just give me the drop rate, please, per minute, so I can just punch it into the fluid and into the system and it can just start. You have to know, okay? Now, when you are thinking about drop factors, it's found on the IV tubing or the packaging. Different tubes or different IV tubes have different drop factors. So you have macro tubes and you have micro tubes. Okay, now here's a nice calculation. Fluid volume over time in drops per minute. So you take the volume of the fluid, okay, in minutes. So you're not going to take this value of 1600. You have to convert this all the way down to hours. So 1600 ml in 24 hours will be 16 ml per hour. Okay, so the volume over 1 hour and the drop factor depends on whether you're using macro tubing or micro tubing. If you're using macro tubing, then you have your 10 drops per minute, or you have your micro tubing with your 60 drops per minute. Sorry, the other way around. Okay. Now, a big thing also is to find out, will you have to really rely on calculators? Guys, review your mathematics. How many times have we looked for calculators on the unit and they are not there? Because now all people do is walk around with phones. Okay, but sometimes you may not even be near your phone. You may need to calculate this when you're already gowned and gloved and you're working with an anesthetist. So mathematics is important. Some of you are not frowning like, oh, come on. You mean we don't have calculators? It's the NHS. Okay, but take the station to another level. All right, just in case you're working with a nurse who really just wants to know the drops per minute. A nice easy way, if you use a drip factor of 60, then it just remains the same, because you have your 67 ml over 1 hour, time in minutes times 60, so you're converting that time into minutes, and your drop factor is 60. So it still remains the same answer. But if you're using a different type of tubing, then the drop factor changes. Fantastic way to teach the student. But the main essence, why would I want to, what would I now go for my safety netting? Or what are my finishing words with this student? I want to make sure that if I give them a child is 50 kilos, will they tell me how much fluids we can give? Can they calculate it all the way down to mLs per hour? Okay, what do they need to know if we need to add fluids and they are not sure? Call the pharmacist, check with a nurse, check with a doctor. How do you assess fluid status in a child? The same way as you assess in an adult. If you are really meticulous about fluids, then you need what else? Inputs and outputs. Okay, you need to measure that and record it per shift, because sometimes if the 7 to 3 shift, the patient has a fluid overload of 1000 ml, then for the next concurrent shift, we have to reevaluate. And that's the big thing. Just because the doctor has ordered fluids in the morning doesn't mean that in the afternoon we'll be giving the same fluids. What is happening here? What is happening with the volume status? Okay, please. These are some of the things that are very important in your teaching sessions. Okay, I'll answer your questions during the break. How are we doing with time? Oh, perfectly. Let's move on then now to another level of good teaching. Let's do a little bit more teaching today. You are the FY2 in neurology. Goodness, today you have been told to teach the medical students about cerebellar ataxia. Why am I bringing this station? Because I have a friend, in neurosurgery, and honestly, the last time he looked at the cerebellum, it was embarrassing. Okay, the last time he actually looked at the anatomy of a cerebellum was a long time ago, and so he was put into a situation and was told, "Hey, can you go prepare a lecture on the cerebellum and cerebellar ataxia and teach the medical students?" Wow. Do you know how much there is to teach? And so the thing is, when you're teaching a student in an exam setting about a station that is vast, you have to bring the information to be concise. Okay? There are 100 things you can teach about the respiratory exam. There are 100 things you can teach about an arm exam, including the Tinel's test and all these beautiful things, including the anatomy, including how the nerves and the veins. Do you have all that time? Okay. Now, if you are worried about what exactly should I teach a student, because some students were coming and they don't have any objectives. They are just there to get the points so you can sign them off for CPDs. Okay, so you want to teach essential things, and do these things that you're teaching have clinical relevance? You always want to tie it to clinical relevance. So let's go through this case. You have medical students present, Samantha, James, and Peter. Whoa, what do you do if you have 3 students? One of them is a smarty pants, Samantha. James is just average, and Peter is struggling to get by. You can even tell he's been eating burgers and he just has, tomato ketchup on his shirt. He's really here, but he's not. Okay, so you have to be able to accommodate to the student who is struggling the most. Leave all these smarty pants students. Even you, I know you are a smarty pants student. But the teacher has to cater to the one who's really not getting it. So you go into the room, hello, how is everybody doing? You're looking at everybody's eyes, good eye contact. Forget about your struggles with shyness. Nobody cares. You have 8 minutes just to be in a different persona and do what you need to do, and then go outside and cry. Yeah, so you have to hold it together as a teacher. Never go into a room and just say, oh, it's been such a long time since I talked. What are you talking about? You are the doctor. You know everything. Okay, so you can't just go in and start making excuses. Goodness, it really reduces the confidence of whoever you're teaching. Yeah. Now, Samantha, yes. James, good. And Peter, fantastic. Can I just know a little bit about each of you? Are you in the same class? I'm a second year, I'm a fourth year, I'm just starting out. Okay, that's good. Have you attended any neurological system teaching trainings before? No, neurological trainings at all? Okay, so let's do this. I'll start at a very basic level and I'll try and advance it. There's a lot to cover. Are you going to start? Samantha, how are you coping? Peter, how are you coping? James, how are you? No. Okay, nice and general. Find out, have they done anatomy? Do they know about the neurological system? Today we are going to focus on the cerebellum. Can someone tell me where the cerebellum is? Samantha. So the lower part of the brain. In fact, the cerebellum is called the little brain. Okay, thank you so much, Samantha. I can see you've done your homework. Very good. What if Samantha is just yapping, answering all the questions? You want to tell her, okay, we know you're smart. Okay, Samantha, let's give a chance to Peter and James also to answer the questions, because through answering the question, I'll be able to see where you need more training. So let's go in turns. Samantha, you answer one question, James, you answer another one, and then Peter, you answer another one. Okay, order. It would be such a beautiful station, honestly. Anyways, so introduction you've done. You've gauged their understanding. the cerebellum. Would I even take it another level? Because I love to draw. I would grab the pen and paper and I would say, so who can draw for me, just the picture of a brain showing where the cerebellum is. Try and draw. Or even you as a doctor, just draw the thing. One big blob for the cerebral hemisphere and another small blob for the cerebellum and another one for the midbrain. Make it a bit interactive. I always laugh when I hear a doctor say, I'm really not a good artist. I usually say, I'm a fantastic artist. I would have even been an artist in a different lifetime. Draw a good picture. Crack a few jokes, not too many. Just say something small to relieve the tension in the room. And that's why I really managed, if you go into our YouTube playlists, there are so many videos I've put in there on communication skills. Non-medical, just even how to deal with people, what to say, how not to be awkward, not just staring people and talking and blinking every now and then. No, how to be personable. These are things that make you increase in a connection with whoever you're teaching. Can you imagine if I just came here and maybe I didn't even put nice earrings for you in the class? I just had my my regular, put effort. Fine, I'm at home and I have 4 hours in the middle of my day to teach. Can I just put a little, Dr. Leon, can you put a little oil on your face? Show that you're invested. Even with the students, smile a little bit, show you are a little invested. Okay, so now back to this. What are the objectives? Do each one of them have an objective, or are they just there to buy the time? Then you also have objectives, because your objectives have to be connected to clinical relevance. Cerebellar ataxia. You just can't just say it's a disorder where the patient is just wobbling like this and they have nystagmus, past pointing, they can't, do the heel to shin. Please. Let's start with the functions of the cerebellum. Okay. How many of you, do you know a function of the cerebellum? Balance, good. Another one, coordination. And how do I remember the functions of the cerebellum? I think of the deficits that we use to check for cerebellar ataxia. That's how you know the function. You have coordinated movement, coordinated eye movement. Sometimes it assists with posture and balance, gait. Okay, so there are things you don't really need to memorize. Okay, other things, coordination of goal-directed and spontaneous movement, motor learning, some cognitive functions like language, riding a bike, and recent research has it like people who are really expert musicians have found a way to use their cerebellum. The rest of us who just know how to play drums, zero cerebellar function. Mozart and all these other people, they've maximized the use of the cerebellum. Okay, anyways, enough jokes. When do you want to assess the cerebellum, Peter? I don't know. Okay, can James help him? I also don't know. Samantha, maybe you have a little bit of input. When do you want to assess the cerebellum? You want to assess it if you see the patient coming in with specific deficits. For example, if they have a stroke, if they have had a history of chronic alcoholic abuse, okay, or alcoholic use, and if they have some degenerative disorders like Parkinson's. The list is not conclusive, but these are some of the things you want to keep in mind. Stroke patients assess cerebellum. Alcoholic patients assess cerebellum. Degenerative disorders assess cerebellum. Head injuries assess cerebellum, because the cerebellum will be able to tell you what half of the body is injured. Okay, it's divided into 2 hemispheres. Okay, and each hemisphere controls the ipsilateral half. So the right hemisphere will control the right side and the left will control the left. Okay, it's a little bit different with different other regions of the brain. Now, What else would you want to do? I would want to maybe just talk a little bit in detail about the cerebellum, and maybe, you know, if I'm really having a good day, we'll talk about the different parts and what affects each area, so that when you start teaching them how to do the cerebellum exam, okay, which takes 2 minutes to do anyways, at least they'll be able to know that my vestibulocerebellum is what controls eye movements. So if I have a patient with nystagmus, I know that my vestibulocerebellum is damaged or has a lesion. Oh, beautiful, beautiful. Even as it'll rain that day, the world will be happy, because you've made an association to their theory and you've made a link. So theory, practical, and then the patient. Never just go teach a student how to do an exam and just tell the patient to do range of motion, lift up and down, do. Why are you doing these things? It has to be associated with clinical relevance. Okay. Now, another thing, there are different lobes, we can talk about that later, but what is important is the vestibulocerebellum, the spinocerebellum, and the cerebellum. Okay, voluntary activity, so your pass pointing and your regulation of muscle tone, coordination of skilled voluntary movement is right here, your spinocerebellum. Nice and brief. Do you need to start talking about the blood supply? God bless you, as you're trying to talk about, you know, we have the circle of Willis, and then you have the pica, the AICA. They are different, the posterior inferior cerebellar arteries, and they flow like you will actually lose points for trying to be too informative in a way that the student cannot comprehend. Because with every single student teaching, and they do it in my hospital, after you leave the room, a feedback is sent to them and they are told, did this doctor suck? Yes, absolutely. They use medical jargon for the whole time. I didn't understand. How can Dr. Lian improve? And I also do that for my I don't think you guys have gotten your evaluations of me. I tell people, please evaluate me so you can tell me what I'm doing wrong. One doctor actually says she has a very thick accent. I said, sorry, I'll try and improve. Okay, but wait till you speak to Irish and Scottish, you know, indwelling villagers. You will know accents. Or people who are from Kenya, deep in the root of Kiamombogo County, you will know a real accent. Yeah. Okay, but the feedback is done. Do you think maybe they do feedbacks in the exam? Who knows? But I would expect that. You taught somebody something. Were you personable? Did you ask appropriate questions? Did you make the teaching session fun? Were you confident? Did you know your stuff? Please, okay? Now, when you're about to teach them the Cerebellar exam, then now you want it to be systematic. So I'll always start by saying, maybe, who's going to volunteer to be the patient? And everybody can volunteer for one different area. So Samantha, you be the first one, because you're a know-it-all. You're going to be my first patient. So the first thing you want to assess is speech. So you want to tell the patient to say the words British Constitution. Please repeat after me. British Constitution. Another word they can repeat is baby hippopotamus. Baby hippopotamus. If you find that the patient is stuttering, or what is called scanned speech, British Constitution, I want you to stop and reassure that patient. You want to say, okay, it seems like it's a bit hard for you to pronounce that word. Can you pronounce baby hippopotamus? Baby hippopotamus. Okay. Again, you want to reassure the patient that you will tell them reasons why this could be occurring. It is scary to the patient. Okay. Next is the H test. Do you remember what part of the cerebellum is for eye coordination? Who can tell me? 1, 2, 3. That's how you do it. H test, you teach it a fantastic way. Okay, so you couple at least arm's length from the patient, finger in the front, fix the eyes and follow the tip of my finger. H test. Okay, of course this is in a small scale so that I'm not just moving away from the screen, but you want to do a nice good H test. Do you want to talk about the medial rectus, the lateral rectus? God help you, you're not going to finish the station. So you want to check if the eyes, if the patient, you're moving your finger this way and the eyes are going like that. That's nystagmus. And I can show you some videos when we go to the library. Okay, dysdiadokinesia. Who's next as our volunteer? Peter. This is dysdiadokinesia. Tell the patient to have this arm, this hand motion, and you move rapidly. 1, 2, 1, 2, 1, 2, 1, 2. Don't forget to test the other side also. Okay, then there is the finger to the nose test. So the doctor tells the patient, touch your nose and then touch my finger. Boom. You want to move it in different planes, okay, to see can they actually move with your finger. Are they past pointing? Past pointing. There is a lesion or there's a problem in the cerebellum. Okay, the heel shin test can be done lying down or sitting up. If they are lying down, the heel goes to the shin, moves up and moves down, moves up and moves down. You can demonstrate it even by yourself. Okay, if the patient is stable enough, you want to have them walk. If they are not stable, do not have them walk. All right, you may want to have a nurse or physical therapy. If a patient is complaining of instability, you do not want to add to their troubles by having them fall. Okay, how are we doing? Oh, good. Yeah, now the Romberg test is another test that can be done to assess the cerebellum, okay? But there are different variants of how to do the test. Does it add any benefit? If it's done correctly, okay? But again, if the patient is dizzy, if the patient is having instability, doing the Romberg test may even put them in a higher risk. Okay, there are different ways you can do it. Have the patient put their feet together, close their eyes, and watch them drift. Guys, there are so many ways to do the Romberg test. And even when I checked with my consultant, it's like, come on, people still do that. If you already have 1, 2, 3, 4, 5, 6 things that are positive, go ahead and make your diagnosis or a preliminary diagnosis. And that's what you want to tell the students. Sometimes you may have positive factors that are leading towards a diagnosis. So you can give a preliminary diagnosis until you do further imaging of the cerebellum to see if there's any lesion. Okay, but the patients are scared. You want to try and reassure them to some extent. Okay, we are going to do everything that we can to investigate and see what is causing these deficits. Okay, sometimes they are reversible. Sometimes they need you to work with a physical therapist. Sometimes they need different approaches. Don't tell the patient that they need surgery. How do they need surgery? You've not even done any scan. So sometimes you can get deducted for points because you're teaching the student the wrong thing. This is a fantastic way. Now, another big thing, clinical symptoms, I said, anyone who has hypotonia, intentional tremors, okay, unsteady gait, slurred and disjointed speech. You want to assess that cerebellum, okay? Again, the cerebellum is called the little brain at the base right here. Draw it out. Know a little bit about the cerebellar functions, please, because just in case you have to teach it to a student. Okay, can we push for one more case and then, oh good, I forgot about this slide. So let's do this slide and then we'll take our little break. Now, a nice way to remember the manifestations of cerebellar ataxia is with the word Danish. And I got this from Teach Me Anatomy. Dysdiadokinesia, so there's difficulty in carrying out rapid and alternating movements, okay? Ataxia, so you may have them walk at some point. Nystagmus, intentional tremor, you may see with the past pointing, okay? Or when you're doing the finger to the nose test. the scanning of the speech when you're doing your baby hippopotamus and your British Constitution, and just generalized hypotonia. So, does the student understand what you said? Peter, one question for you. Did you get it? Samantha, did you get it? How about you, James? Do you have any questions for me? Okay, so what will you do if you assess a patient and you find these things? What is the clinical relevance? Tell somebody about it. And for the future, don't just limit your knowledge to knowing about the cerebellum. The brain is vast. You need to look at some anatomy, and don't just read anatomy without adding physiology and pathophysiology to it. That way you can make a good association. And you know, if we have a patient who has suspicion of cerebellar ataxia, okay, or a cerebellar dysfunction, I'll make sure that, you know, of course, with their permission, I can have you come into the room during the assessment, and now you can see it in a patient. That way it will be able to reinforce this knowledge. Can you leave your students with something for the future? Videos, another teaching session, interactive rounds in the clinic, library resources, books and videos. Now, of course, you're not going to be that overzealous doctor who's just waiting. Oh, I have to shine. I have to show the examiner that I am taking care of my student for the future. I'm going to give you videos. I'm going to give you my medical books. I'm going to invite you to this to surgical resection of cerebellar neurosurgery. I'm also going to send you to the consultant for his teachings, and you can, golly, two things is enough. Okay, you want your words to be like apples of gold on settings of silver. Beautiful. Okay, nice place to stop. So anyway, let's go for our break. I'm going to give you your questions for the maybe we'll do one more case and then we'll do our mocks. We might extend just a little bit today. Okay, so 10-minute break, and then we'll come back and do our one more station and then the mocks. Okay, ciao. Okay, very good. So we are back from our break, yes? And the mock question was, so the first two people to give me an answer. Now, Dr. Stella has answered twice. You want her to do another mock? Okay, you have to try and beat Dr. Stella. Maybe Dr. Stella, if you don't want to do this mock, you can give it to somebody else, but I would say do it. Anyways, here, give me 5 components assessed in the Wells score for DVT assessment. Heart rate, immobilizations, previous DVT, malignancy, and hemoptysis. Okay, pulmonary embolism, heart rate, previous DVT, immobilization at least 3 days, and hemoptysis. You know, you people, honestly, how many are you in this class? There's so many of you. I don't want to tell you to cheat, but if you don't know the answer, you can just cut and paste somebody's response. To get a chance to do a mock. Anyway, but it's not good to be dishonest, so I'm happy that you didn't do that, okay? Let me read you the answers. So at least because Dr. Dar has attempted and Dr. Okoro has also attempted, they'll be the ones to do the mock. So tomorrow, we'll see. Let me read this to you. Page 450 of the Oxford Handbook, yeah? I'm talking about it like I work for them. It's such a good book anyways. Anyway, so pre-test probability in DVT. Symptoms and signs of DVT are non-specific, okay? Likewise, the match over ordered D-dimer blood test is a non-specific marker for thrombosis. So if you have a patient who is coming in and you have a high suspicion of DVT, it's important maybe, and sometimes what we do is we talk to the patients and we tell them, I have a high suspicion for you to have a clot in your leg. Why? Because of the following things. Either they have pitting edema, they have tenderness along the veins, okay? The whole leg is swollen, including more than 3 centimeters of calf swelling. So when you're talking to such a patient, what do you want to say? Can I check your lower extremity? I want to make sure that the area is not too the temperature is not too off compared to the other foot. I need to make sure that it is not swollen also, that you have positive pulses. I need to do a measurement of your calf muscles also, and make sure it's not more than 3 centimeters more than the other calf, as opposed to another doctor who just comes and says, I'm going to do D-dimers. Come on, you may want to say you have an underlying history of atrial fibrillation, you've not been compliant with your medications, so that's another reason why you could be having the pain in the leg. There are many reasons for unilateral leg pain or leg pain on one side of the body or on one leg. It could be an infection, it could be a clot, okay, it could be some insufficiencies inside the vein, so your veins are really not working that well, okay. But I can calculate what is known as a Wells score and see your risk for having the DVT. What if a patient comes in and says to you, oh, my brother had a clot in his leg. Am I at a risk of getting clots in my leg? Oh, thank you very much. Let me calculate the Wells score to find out his risk, because some people just say, oh, there are modifiable factors and there are non-modifiable factors. Your family history, your whatever, you're smoking, you're doing all these things. No, sometimes in medicine, for us to progress, we need to have objective and objective information. So a patient comes and tells you, I'm dizzy, I'm dizzy, I'm dizzy. Okay, let me check your vital signs. The subjective is what the patient is saying. The objective is my vital signs, because my objective information is what is going to reinforce what the patient has said and make me do an intervention. Doctor, I'm so worried about getting a stroke. Oh yeah, I think you're heavy. Maybe you can get, maybe you cannot get. Can you do a Q-risk score? Let's calculate your Q risk. Let's make sure your blood pressure, let's see if your cholesterol levels are high, your BMI levels, all these other things. Do you have underlying atrial fibrillation? All these things will give me a percentage, including chronic kidney disease, yeah? All these things will give me a percentage value to know whether you're at risk for a stroke or not. Because if you're at risk of a stroke, and your Q risk is 10%, we need to give you some medications to reduce the risk for a stroke, statins. Okay, doctor, I'm coughing. Do I need antibiotics? Let's calculate the carb 65. Do you see where I'm going? Please, you need to go and make yourself a nice little chart with objective assessments. Okay, doctor, I need to a liver transplant. There's a different score. Doctor, I have pancreatitis. There's the bicep score. Come on. All right, so other measures. So I'm going to give these two doctors a mock, yeah? But let me just tell you other things. So you have more than 3 centimeters of calf swelling compared to the other leg, okay? Recent bed rest of more than 3 days, or major surgery within 12 weeks, okay? Previous documented DVTs, somebody mentioned that. Leg paralyzed or in a plaster, okay? And active cancer, treatment ongoing or in the past 6 months, or on palliative care. So those are some nice things for you to estimate. Okay, I think now your probability of having a stroke are high because I've calculated a Wells score and this is where you range. Now, a score of more than 2, likely. Okay, and because the score is more than 2, we may give low molecular weight heparin. If they have a score of less than 1, because for all those little things they get 1 point. So if they have more than 2 factors, they have a high chance of a clot in the leg, and they get low molecular heparin. Yeah. Okay, we may even do an ultrasound test. Okay, so your Dopplers. And then if it's unlikely, then you can throw in all your D-dimer tests and the rest. But will you give heparin for a score less than 1? Maybe not. Okay, so that's a nice little way. Honestly, if you can open this book once a day for the next 365 days, you have finished it by the end of next year, July. Okay, let us go into, it's 129, 30, 40, 50. let's do the mock. You know what? I'll keep the case that I had for today for tomorrow, because I want to spend a little bit more time on the cases that I've given you for the mock, right? So our first doctor, Dr. Dar, can you please stand up? Sorry, I didn't give you time maybe to go and prepare, make the hair do. You're going to be on TV, on camera. Let me share the screen, and nice to see you. Let me just make sure also that I can unmute you so that you can be able to talk to us. Very good. Bit more, allow. Very good. This is how I get to meet all the doctors. It's a nice way. Can you hear me, Dr. Dar? Are you able to allow? Okay, yes, I've allowed you to unmute yourself. Maybe you can try and unmute yourself.
Yes.
Perfect.
Yes.
Perfect. Okay, so I have my timer on. Everybody is going to refrain from trying to help Dr. Dar, and she's going to read the question, and then we shall go ahead. Let me know when you're ready, yeah?
Yes.
Okay. Also, let me just test if you can hear this timer.
Anticipation.
Yes, I can hear.
Let me just make sure that we are good. Okay. So, are you ready?
Yes, doctor.
Okay, good. Good luck.
Anticipation.
Hello, my name is Dr. Moshi. I'm one of the junior doctors here. Can you just confirm your identity, please?
My name is Samantha Jones.
And your age, please?
I'm 65 years old.
Thank you for coming in, Samantha. How can I help you?
You know, I have a broken leg. You know, I was just told to come and follow up with my GP, because I don't know why. I don't know why I broke my leg.
Thank you very much for keeping your appointment, Samantha. So, so can you please tell me what happened that you broke in your leg?
Oh, honestly, I was walking down the stairs and I just tripped. I just tripped. 1 minute I'm standing, and the next minute I was on the floor.
I'm so sorry to hear about this, Samantha. Can you please tell me how many days ago was that?
Well, this was actually a week ago.
Okay, all right. And what happened after that?
I'm sorry?
Who brought you to the hospital then?
Oh,
What happened after that?
yeah, my daughter brought me to the hospital, and then they put this big plaster on my leg. But now, you know, I'm just here for follow-up.
Yes, Samantha. So, how are you doing right now?
I'm just trying my level best just to hobble around the house. I'm not working, you know. So.
Do you have any pain right now?
No, I don't have any pain.
Any swelling in your leg?
No, it's all covered in this white case, but it's not swollen, no.
All right. Samantha, by any chance, have you had any fever?
Fever, no, doctor.
Anything else? Have you noticed that's bothering you?
Actually, I have some concerns. I just want to know, how are my legs just breaking, I don't know.
Yes, definitely, Samantha. I am here to address your concern. So, can you just tell me that do you have any other medical condition at all?
No, not that I know of, no.
All right. Are you taking any medication for anything?
I'm just getting some pain medication.
Okay. And any allergy to any food or medication particularly?
No. Why are
Okay,
you
Samantha,
asking
this
me all these
is quite
questions?
reassuring. Actually, Samantha, I'm just trying to get into the point why this has happened to you, and I'm trying to find out that whether you're fine or not.
Okay.
So, Samantha, can you please tell me that what happened before the incident that you have fallen down? have you noticed anything unusual before that?
Oh, unusual like what?
Any heart racing?
No, doctor.
Have you noticed that any drowsiness or dizziness before that?
No, doctor.
What were you doing at that time before the fall?
Oh, I was just going downstairs to get a cup of water.
And then you fall down. All right. And when was you taking your last meal before the fall?
Oh, I had dinner. I had dinner around 8, but I woke up at around midnight. Yeah.
Okay. And at that time, have you noticed any sweating or any shakiness?
No, like shaking the body?
Shakiness of your hands?
Oh, no, doctor, no.
Not like that. All right, Samantha. And what happened after that? Have you, by any chance, injured yourself by any means, by the fall?
Yes, my leg broke.
Yes, yes. Actually, I'm telling about any injury in your head.
Oh, no.
Or like,
I didn't hit my head. Yeah.
okay. And by any chance, do you know that anyone tell you that you lost your consciousness?
No, I did not lose consciousness. No.
Didn't? All right, Samantha. Did anyone witness you at that time when you fell down?
I'm sorry, doctor?
Did anyone witness you at that time?
Oh, witness.
Who was it?
No, it was at night. It was at night.
All right, Samantha. So actually, I was trying to get the point why this has happened to you. But can you just tell me that when you fell down, were there sufficient light at that time?
Light, you said?
Yes, light.
Oh, yeah, there was enough light, yes.
All right. So what is your idea? Why you fell down? Any idea about?
I don't know. I don't even know why I just fell and broke my leg. Yeah.
Okay.
And last month I broke my hand.
All right. Okay. So and how did this manage at that time?
How did they fix it?
Yes. How did they fix it?
Oh, they put a cast on it also. But I'm wondering, I broke my hand, I broke my leg. Yeah.
So it is such a difficult situation for you, Samantha. Okay. Okay. So thanks for answering all my questions. I would like to examine you now. I'd like to take your vitals and do a general physical examination from your head to toe, and I'd also like to have a look at your legs to see how are you doing with this task.
Okay.
And also
you take the cast off?
No. I will just check that if you have developed any complications for the cast.
Okay.
Or any change, I will check your leg for any swelling, any abnormality.
Oh.
So Samantha, actually I have three possibilities in my mind to find about your fall. So I would like to know some tests to find out what actually happened to you.
Okay.
I would like to run routine blood test, do your heart tracing, and also check your vitamin D level. And since you have said that you have broken your hand 1 month back, so I would also like to check your bone density, that if you have any abnormality on that. Would they be okay with you?
Yes, I guess, yeah.
And of course, I will check it with my senior before running the test. So Samantha, from the information what you have given to me, I'm suspecting that you, considering your age and all the things, that you might have some condition in your bone, that you might have thinning of your bone, that what we call osteoporosis. Am I clear to you?
Oh, osteoporosis?
Yes, it is called osteoporosis. Actually, it is the thinning of the bone that actually happen when with the ages. So I am suspecting that it might be the case with you.
Okay. End of station. Move to the next station. Good. All right. Now, tell me what you could have done differently, and let me open this chart so that we can see what people will advise you to do also. Please, I have an emergency. Can you, okay. Yes, Dr. Ibere can take your place. Doctors, can you give her some input about how she did this case? And at the same time, Dr. Dar, tell me how you could have done this case differently.
Yes, I could ask about what happened before because I asked you about the past medical history, and then I proceed to the what happened before and what happened after that.
Good.
And another thing is that I just missed very important for this NAI. Is an elderly lady. I should search for that.
Yes, yes, you did it really well, but NAI should have been all the way at the top.
Yes, yes.
Yes, that one should
It's
have been
yes.
all the way at the top. And so not even starting from, you see what everybody's saying, okay, NAI steroids, okay, that's really good. Now the thing is here, when you start the case, you came in and you said, how can I help you?
Yes.
But you had the information in the question that was saying she has been discharged from the hospital after a leg fracture.
Mm-hmm.
So sometimes it's good to come into the station to say, hello, my name is Dr. Musimi, and I'm one of the juniors in the GP clinic. Can I confirm your name? Yes, yes. Have a little bit of information so you don't ask the patient, how can I help you, or what are you doing here? Yeah, so at least just to say, I can see you've been discharged from the hospital after a leg fracture. How are you doing? Even pain level should have been all the way at the top. How are you doing now? Are you hurting at all? Okay, who brought you to the clinic? So that now you can have a bit of social medicine to increase the interpersonal skills and not just dive into the differentials.
Mm-hmm.
Yeah? You did well. I like that you did well, but you started your medical conditions, allergies. There was no family history, which I could have told you that my mother also has broken bones. Alcoholic, no smoking, no alcohol, which is important just to continue. Finish your past medical history properly. You spent a lot of time with your differentials. So these are your differentials. Was your heart racing? Were you dizzy? Did you have a last meal? Were you sweaty? Were you shaking? So you found out that it was not hypoglycemia, but then you kept asking more about hypoglycemia. And it took a little bit of your time. Yeah. Loss of consciousness. I think you asked about this, the light also. And I would have been good to get. But you kind of caught up in the last 2 minutes, which I was happy. The big thing about the last 2 minutes, don't show that you're aware of the 2 minutes. Okay, now I'm going to start giving you some investigations. I need to do your vital signs. I need to do your management. You don't want to show that you know it's 2 minutes. Yeah, so even if you hear like the 2-minute bell is ringing, you want to maybe finish your last train of thought and just say, okay, let me give you a recap, but don't even change your body position and don't change your pace. Yeah, you managed to recover in the last 2 minutes, which is good. You wanted to do vital signs or head to toe assessment. You have to be careful about that, because what if the simulator says to you, okay, go ahead, do a head to toe assessment? You'll be trapped, because they'll say, you said you want to do head to toe. So focus on the area first. Let me just take a look at the leg. Let's see if there's swelling, if there are any complications. That's good. I need to do the routine blood work. Add a little bit more what you need to do, so you're not just saying a blanket routine blood work. I'm glad you said vitamin B and the bone density test. Yeah, but sometimes even the exam is not looking for a diagnosis. So don't be in a rush to say diagnosis also, because it could be different things. It could be because and it might be good to even say, I've asked all these questions to try and find out what is going on. Maybe we'll have a talk about your diet to make sure that you're having good supplements with the vitamin D, calcium also. We also have to make sure NAI is important, because I'm just being merciful. I could have switched it to NAI for you. But what you did really well was to ask what happened before what happened during and what happened after. So you kind of helped yourself, because if it was NAI, it would have been witnessed by someone. Which was very smart. I really liked the way you did the case. Good. Do you have anybody else who's giving her feedback? Good. Yes. The social history is important. Yeah. The social history is important. Somebody else is saying, okay, try not to be too haphazard with the history taking. I felt the differentials were very many. Just shorten it to a few more. Yeah.
So, Dr. Lian, should I act like that? I know that the patient was having leg fracture and she came here for follow-up. So
Yes.
I should act like that.
No, yes, actually,
Exam.
in fact now, why they are giving you all this information is so that you can come in with the information.
Okay.
And it's always so good. For example, and I'm so glad you even said, Samantha, can you confirm your last name and your age? Because it's always so good for the doctor to come in knowing a little bit of information about the patient.
Okay.
Yeah.
So I should act like that. I know some information about the patient.
Yes, because
That
you do. Yes, because you know information. In fact, even just coming in to say, oh, hello, Samantha, can you confirm your last name and your age? I'm very sorry. I can see you had an injury. How are you doing now? The notes tell me you fractured your leg. Which leg? The right one, the left one? Are you in pain now? Are you comfortable? You know, she's sitting on the floor and the leg is dependent. I would say it might be good for me to get you a bit of a stool so that you can elevate the leg. And then even in the end, you can throw in a bit of safety netting. If you feel the leg is cold, if you feel the leg is... So now you used a lot of time in differentials. You could have shortened that in, shorten those differentials, ask the major questions first. So a fracture, has she had any other fractures? So you're thinking, she has had a fracture, what can cause this? Lifestyle, genetics, NAI, yeah? And then the rest. But don't try and get all the little details, because in the end, your safety netting would have really helped to boost the case. You know,
so it is better to ask one question for one differential. Like if when I ask that when was last meal, I exclude hypoglycemia. Right?
Yeah, I usually do the major differentials first. I do the major ones. And if you found out that, you know, she ate a meal and she was not dizzy, let it go. So you don't have to say sweating, dizzy, because then now she's already told you she had the meal. So she closed that door for you to try and help you. Yeah. It's a really good test, because sometimes people still forget to do the safety netting. Okay, good. People are saying good attempt, good attempt. Yes, you actually did a good attempt. Safety netting about compartment syndrome would have also been good. Yes, only if she's come for a follow-up visit. What else could she have mentioned in the management? The management in this case is important to find out the cause. That's why I liked that you said vitamin D and bone density. And you said because you had another fracture and because of your age. Really nice.
Thank you.
Because now you're showing the patient a little bit of insight. Why I'm doing this is because of this. So I'm not just ordering a bone density exam for you. It's because you're above the age of 65, you had a recent fracture, you know, and then now, and I also do a vitamin D level. Let's see, what was the patient says? The question says that the patient has concerns, but I didn't hear anyone. Yes, sometimes it may say I have concerns, but I don't have. But I'm glad that you asked me if I had any concerns, but I didn't. That was good. It was a good mock for you. And of course, you know, I don't give points for mocks. I either say you fail or you pass. So I give you some good points for this one.
Thank you very much.
You're very welcome. Do you have any other questions?
No, thank you very much.
Good job. Okay, so who is the next one? I think I see Dr. Stella gave her mock to Dr. Dominic Ebere. Is he around? Yes. Okay, Dr. Dominic. Let's see if you can please unmute your mic. I sip my tea. Okay, good. How are you, Dr. Dominic? Hello? Hello, Dr. Dominic, can you hear me? Dr. Dominic, can you hear me?
Yeah.
You're having a little bit of a network lag.
Yes, I can hear you.
Okay, good, good, good. How are you doing?
Yes, I can, yes.
I think there's a small, a short lag there. Let's see if we can you can hear me clearly?
Hello?
Yeah,
Hello?
yes, your network is not too good.
Yeah, I can hear you. I can hear you.
Okay, good. Can you hear the timer?
Hello?
Enter station.
You can hear the timer also? I don't know if Dr. Dominic has good network. And I thank you, doctors, for being patient. It's good to practice patience also. You know, if Dr. Dominic cannot do the mock today, what we can do is we can let him do the mock tomorrow. Yeah. He seems to have disappeared. Okay, Dr. Busola, you have a question for me? You know what we can do is, I don't want to, yes, please type in your question, please. What we can do is, because Dr. Dominic might be having some problems with his network, what we can do, let's have him do it tomorrow. Dr. Busola wants to try a mock also, and I don't want to keep us too much. So let me do this. I'll give a question for tomorrow, and Dr. Busola, you're going to try and answer that question specifically. Okay. Dr. Dominic, I still have to give him this mock, so we'll do it for him for tomorrow. And since it's 1:52 p.m., let me just wind up the session so that those who need to go can go. All right. I will hang around for a little while and we can just discuss another case briefly, but let me just wind up the lesson and say that this completes day 3. So we'll see you tomorrow for day 4. Okay. Have a good night.